So I just started the recording. So again, I'm Tanya Glantz from Rhode Island College, and we're joined today by Linda Mahoney. Very excited. She's actually provided some different materials, some new materials. So I will be sending those to you, and they'll go right in that manual that you guys are going to get. I took a quick peek at it. It's pretty exciting stuff, and she has a poll that we're going to start out with. Linda, do you want to say a little bit about yourself?
Why don't we introduce everyone first, and then I can finish up. How's that?
All right, that's beautiful.
I want to hear from who we got here.
All right, excellent. So I'll just spotlight people. Andrew.
Hi, I'm Andrew. I work in the South County East Bay region.
Welcome. All right, we're gonna, let's see. Jenna.
Hi, my name is Jenna Landsman, and I am a tracker for the Kent County region.
Excellent, welcome. All right, let's see, I'm going across. We got Kelly.
Hi, I'm Kelly. I am an outreach tracker in the Pawtucket region.
Excellent, wow, we got, the whole state is getting covered here. It's beautiful. All right, we're gonna go to Willie.
Hi, my name is William. I also work in the Pawtucket office for tracking.
Excellent, and do you like Willie or William?
Honestly, whichever, it doesn't matter.
It doesn't matter. All right. Both of them are great names. Thanks. Thanks, William or Willie. There we go. All right. And we're going to go next to Sarah.
My name is Sarah, and I work over in the Kent County area as a tracker.
Excellent. Welcome, Sarah. Junior.
Hi, I'm Junior. I'm one of the senior case workers. I work out of the Pawtucket region.
Excellent. Welcome. We're going to go to Emma.
Hi, I'm Emma, and I'm a tracker with Providence.
Welcome, Emma. And then Erin, we've got an E thing going here.
Hi, I'm Erin. I'm a tracker in the Kent County region.
Excellent. And do the folks who are from the same region, do you guys know each other?
Yeah.
Okay, all right. So you have like little clusters of people here. Now you get to expand your group here. All right, let's hear from Devin or Dev.
Hi, my name's Devin, and I'm a tracker from the Providence office, soon to be BA.
Excellent, welcome. All right, let's see. I'm trying to spotlight Jessica, but for some reason it is not letting me. Can you tell us who you are, Jessica?
Hi, I'm Jessica. I'm a caseworker at YTC Providence.
Excellent. All right, let's see. We're going to go to Laura.
Hello, my name is Laura, and I'm a outreach tracker for Woonsocket, Burrville and Japatcha area.
Wow, okay, a lot of territory there. All right, and we have Odessa.
I'm a tracker for Pawtucket.
Excellent, welcome Odessa. And I believe our last person is Michaela.
Hi, I'm Michaela. I'm a tracker with the Woonsocket area.
Excellent, welcome. Did I miss anybody? Got everybody here? All right.
Trey.
Oh, Trey, I'm sorry. You know something, my screen changed. There we go. Thank you for letting me know. Tell us who you are and where you are.
Trey, I work with Andrew at the South County East Bay area.
Wow, so we literally have the whole state represented here. That's pretty amazing. Nice. And I'm hoping that you'll have opportunities throughout the different trainings to talk about some of the different experiences that you're having and to identify areas of either resource or need that we can maybe through these trainings and through some of the resources help connect you with. So hopefully this is the beginning of expanding all of our networks. Linda?
Hi. Well, welcome. My name is Linda Mahoney, and I work for the Department of Behavioral Health, Developmental Disabilities, and Hospitals, the longest name in government. But we can go into a little bit more detail about what BHDDH does. But just so you know that I ran an adolescent treatment program for 13 years called Cohort House, which is a boys' residential facility. So working with adolescents is close to my heart. And I trained many individuals coming through internship programs. And, you know, some people can work with adolescents and young adults, and some people can't. That's why it's really important to build a workforce, because, you know, kids know when you're being a phony and you just don't connect, but they also know when you do connect. So sounds like you have a really great opportunity. I have a credit card bill maybe you can help me with.
Yeah, right.
Anyway.
You got to be in training, Linda. You can't just give the training.
You got a great opportunity. So for me, I like to start with just to find out how much experience you have, you know, where you're coming from, things along that line. So I asked Tanya to put up a poll, keep you active. And most of this, unfortunately, is going to be a lot of just most class education, because my job, I'm understanding it, is to let you know where resources are. So when you need to tap into them, you know exactly where to find them, which is a little dry in presentations. And I can't get up and, you know, run around the room because it's just a different world. So we're going to start with this poll question.
Okay. So what I'm going to ask folks to do is you can either open up a new window on your computer, or you can use your smartphone, and you're going to go to www.menti.com. And when you get there, you're going to put in the numeric code that you see. 5730076. And what that's going to do is it's going to take us to an online poll, and we'll be able to have everybody provide feedback to all of the questions at the same time. Are any of you guys familiar with My Menti? Nope. So this is actually kind of a neat tool to give everyone a chance to participate. I can actually pop a copy of this into the chat if that's easier for some folks, just to click on it. And I'll give a second before I advance the slide to Linda's first question. Everybody able to access it okay? Okay, all right, so I'm gonna move forward to the next slide, which is the first question. How long have you been working with individuals with a substance use disorder or mental health issues in the position as case manager? Okay, so I think we have, how many folks do we have in the class right now? We have 17. So we have two more folks to participate. Anybody having any difficulty? So it looks like we have 4 people who have been doing this for a little while, and then we have almost the same. We have 9, so almost twice as many people, a little over twice as many, who are relatively new to this. So there's probably a lot that we can learn from each other, and the enthusiasm of people who are new to the field. I always find myself kind of sustained by that. So it's a nice combination. Let's go to the next question. I am aware of the workbook Taking Charge that focuses on adolescent education and resources for transitional youth. That would be a big no for me, because until Linda just showed it to me this morning, I'd never seen it. Is that a new publication, Linda?
No, 2019.
Wow. Okay.
It's in English and in Spanish.
That's terrific.
I checked to see, and some were delivered, but you know, that may have been pre-COVID, so.
Right. Anybody else going to weigh in? We have 11 of the 15 people. And if you're not, if 12, okay. If you're not answering, I'm just wondering if you're having any trouble just using the tool. 13. That's what we had for the last one. So it seems like this is an opportunity to expose all of us to this resource. And I'm sure people will be excited to actually get the hard copy. And let's go to I think your last question. Are you familiar with the terminology recovery friendly? Let's try to get that 13 at least on this one. Okay, so it seems like there's a real opportunity with the information you're going to be sharing today, Linda, to expand what we already know and to maybe create some opportunities for new knowledge. So I think that's a real opportunity in terms of the subject matter that you're talking about, and especially when you consider just the issue of addiction and how pervasive it is. I would suspect, based on my many years in the field, that you're not going to interact with, families where there aren't issues of addiction and recovery. I know when I worked in child welfare, it was more than 85, if not 90-something% of the population was impacted in some way by addiction. And the focus on recovery-friendly strategies, I think, is kind of an advance that we've made recently. Anything you want to say about the poll, Linda, before I take it down?
No, but I do this because you should always know your audience, right? So wait, if you have someone in front of you, you should have as much information about them as possible. Because if you're trying to help them, the more information you have about the person, the easier it is to make that connection that I talked about earlier. So I wanted to be able to present information to you that was helpful, not information that wasn't going to meet your needs at all. So we have lots of slides, and I can skip through the ones that I think people already have some knowledge about, and then we can move toward the ones that we need to build on. So if you want to put the PowerPoint up, let's go to work.
You got it.
Thank you.
All right. And I just so you know, Linda, I embedded that poll in here for the next class.
Oh, perfect.
So
thank you. How come it's a break?
I'm going to put myself on mute, and I'm going to turn off my camera just so that I'm paying attention to this. If anybody needs anything or has questions, please send me a chat. And Linda, you can just let me know when you want me to advance for you.
Sure. So this is the department name. If you hear the name Buddha or BHDDH, most of the time, instead of people saying the whole long spiel, you'll be familiar with that. If you ever need me for anything, that's my phone number. I mean, as administrator and State Opiate Treatment Authority, my job is to work for the citizens of Rhode Island, and that means you. So call if you need anything. If I can't get you the information, I can certainly help you. Next. Slide, please, or am I advancing the slide?
1 second, it's just not letting me advance. Hold on 1 second. Oh, there we go. There we go.
All right, so these are just some basic housekeeping rules. You know, we'll break halfway through, probably somewhere around 11:15, I would think. Interrupt me with chats, questions anytime, you know, because the job is for you to gain information. There's no wrong questions. There's just questions that just don't get asked. So this is your opportunity. I licensed all the facilities in the state of Rhode Island on behavioral health. I'm also the State Opiate Treatment Authority, and got a couple of friends in offices next to me. So we can definitely answer questions for you that you need to. Usually one of my staff members would be running this, but she's out on injury leave. So I changed the slides that you had originally received because she's been out for a long period of time, and I wanted to make sure the information was current. All right, next. This is just our vision. You should always have a vision. Beth Bixby has a vision for TIDES. You should be aware of what TIDES vision is. But our job is to develop innovative evidence-based programs. Our job is by statute to make sure there's good care, good delivery, and the community partners. And we find champions like yourself who can really help us do the work that we need to do in an effective manner. Next. By statute, authority. We are the Substance Abuse Authority and the Mental Health Authority for the state. Little background, if you haven't, you're younger than I, lots younger than I, they may never have heard about LAD school. But at one point in time, LAD school was, well, let's go back. People who had mental illness were put on a farm. And, you know, if you had schizophrenia, you were put away. If you had bipolar, if you had any mental health issues, you were just put away from society and they didn't see you. LAD school was in Exeter on the grounds of where Phoenix House is now. It's a detox program, but the concern were when LAD school closes that we would move people into the community. So they wanted an authority to make sure when people moved into the community with serious persistent mental illness that they were safe. So that's the duties of our director and the duties of our office. So next. So we serve hundreds and thousands of people. So this Venn diagram is to kind of show you the various populations. We have a $426 million budget. We're responsible for 31,000-ish individuals with serious and persistent mental illness and mental illnesses. We have a hospital called Eleanor Slater Hospital, and generally that's the hospital for indigent populations, people who are maybe forensic, that cannot be in society. And also there's a medical side of the hospital for those who might need oxygen at end of life. So we also are responsible for 4,000 individuals with intellectual or developmental disabilities, and also for individuals with substance use disorders. And that's called behavioral health. Most people use that terminology, behavioral health, but don't understand that behavioral health means both mental health and substance use. Next. We fund 33 behavioral health treatment providers, 148 locations throughout the state. Most of our money comes from the federal government. We have SOAR funding, we have block grant funding that pays for anything, Medicaid funding, but this is the scope of everyone that we serve. Next. So what we license and what we do are two different things. We don't license adolescent mental health, we license substance abuse adolescents. But generally for all adult populations, it's everything from prevention to treatment to peer recovery supports. And we're going to go into that a little bit more about the difference between prevention and intervention and treatment. But under the treatment section, you can see the different names for treatment. Just the terminologies in this field is unbelievable. The acronyms, the ASAM and SPMI and all the acronyms that out there. I mean, literally, you almost have to start a list if you're coming into the field because people talk jargon. So I just want to make sure that you understand what some of the acronyms are, but at the same time to understand from an individual's point of view, a patient's point of view, a client's point of view, that using some of them can be confusing for them as well. So try to use the words that explain what we're doing. So general outpatient services, integrated dual diagnosis, that means working with people who have both mental health and substance abuse. They may have either physical problems, but dual problems. We provide medication services. MHPRR, we're going to talk about, that's mental health, psychiatric residential beds. And a lot of the work that we do is also around the substance abuse, medical detoxification services, opiate treatment programs. I'm going to stop for a second. Any questions on any of these? That anybody, I want to get you in easy asking questions about something that you've never heard before that you would like a little bit more explanation about. These are lots of services. All right, well, just pencil it in case you want to ask at the end. Next slide, please. Okay, so primary, if you don't get anything out of this meeting but where to send people if they need help, this is the beginning part, okay? What we've learned through, surveys is that, people, we ask them, why did you get treatment? Why did you get help? Why did you go call someone or ask somebody for help? Very often they'll say, well, I didn't know where to go. So we developed this program, and it was back in 2018. It's an emergency diversion. So what you don't want is somebody who has their first psychotic break to go into emergency room, because that's going to actually increase their anxiety, and it's going to increase the symptoms and this discrimination, and they're going to want to not go back again and not get any help. So BH Link, if you're familiar with it, is a program that is very soothing. You walk in, there's nice music, it's dimmer lights, it's nurses and doctors and people who understand how to deal with a crisis, mental health or substance abuse crisis. And that's not what happens when you go in the emergency room. You go into the emergency room and, what's wrong? And people have to explain that the things that they're feeling or seeing or hearing, they don't want, the first stage of recovery, right, is denial. I don't want people to think that I'm crazy. So they don't talk about it. My experience working with kids is I had kids that would have a first psychotic break, which can happen from 16 to like 25 years old, right? They have their first psychotic break and they use drugs to kind of control the hallucinations. So after you get them in treatment for a little while and go like, this doesn't, you never used drugs before you were like 16. What, you never had this behavior before this. Is there something different that happened? And usually, you might hear, well, yeah, I didn't want to be like my dad. So very often you'll hear that schizophrenia will run in families. So, every child that has a father that has a mental illness thinks, well, this happened to me. Well, I have the same thing. And if their father didn't get or mother didn't get treatment early on, then the disease progresses to the worst end. And people fear that. But if they get treatment, the earlier that they can get treatment, the less symptomatic, and they can have a very good life with schizophrenia. They can have a very good life with bipolar. They can have a very good life with any mental illness. But it's like anything else, you want to get treatment early. So this is a 24-hour day, 7 days a week, 365 days a week access, but they have to be 18 years or older to be able to walk into this facility. Kids Link is a place where they can call and get services, but this is an adult. And I wanted to make sure you had this because, you're also going to run into parents, or you're in the field and all of a sudden I have to tell you, you're going to become experts. People are going to be like, oh, you work at Tides? Well, I have this problem and I have this cousin and, where do I do this? And, I just want to make sure if you don't get anything out of this training, but know that BH Link is the first stop to make a phone call, bilingual, or just to say, hey, listen, let's go to, can I have the next slide, please? Go to the address or recognize it on the commercials that we have out there. 414 Link. They can get on a bus and get there through bus route 34. They can go online and look at bhlink.org, or they can just call. Access is key. Getting people into treatment as soon as possible is imperative. The sooner, the better. It's like substances. The more drugs you use over a longer period of time, the more problems you're going to have in your brain. Your brain is just one organ that you have. You don't get another one. So the more you destroy it, the harder it is to repair it. So getting the brain some help as soon as possible is really important. Next slide, please. BH Link, you're not alone. So since you're from all over the entire state, which is great, I want you to, so Rhode Island is a very small state. We have a little over 1 million people, 1.5 million. but we're the second most densely populated state in the country. New Jersey is more densely populated than we are, but then it's us. So what we have by statute have, when the lad school closed, where all those with seriously mental ill issues went to, when they closed, we opened up community homes throughout the state. And then we placed these community mental health organizations in each area of the state so people could get counseling, they could get their medications, they could get connected without and live in the least restrictive environment as they could. And that's the important part. So Community Care Alliance, as you see here highlighted, is in your top left-hand corner. That covers Woonsocket and Burrville and North Smithfield, Cumberland, Lincoln, that area. The next is probably our largest community mental health center. That's the Providence Center, which covers Providence, but that also has the most densely populated. You have the Thrive, which is now called the Thrive, not the Kent Center, which is but in this book, it's listed here. And I wanted to show you really quick. Most of the things that I'm giving you, you'll be able to find in this book, which is going to be helpful for you, or just to give to one of your clients to look through too. So Thrive is the Kent Center. They changed their name and they cover Coventry, West Greenwich, East Greenwich, Warwick, West Warwick. Next, you have East Bay, and that covers the East Bay, East Providence, Barrington, Warren, and Bristol. And it gets a lot of work from Pawtucket. Some people go to East Bay, some depending on where you live. But Pawtucket is mostly Gateway. Gateway covers a large section, both Pawtucket and Central Falls. And then last, we have Newport County Mental Health, and that covers the islands, Tiverton, Jamestown, and Portsmouth. We also have a group called Fellowship, and they're kind of a national group. They don't have one particular jurisdiction, but anyone, like say someone has an issue with Gateway, they went there and they don't want to ever go back there again, they could go to Fellowship. Fellowship tries to cover those other entities, like those coming out of prison, or those who are homeless, or those who might but they do a really good job and have other group homes. Next. All right, so I told you I'd give you some acronyms. There's no test on this, but I wanted to make sure you're aware of these for adults. These are adults. In adult mental health organizations, they're called CMHOs, or community mental health. That's the easier name you probably hear. Find a CMHO close to them where they can go. And that's the map I just showed you a minute ago. If someone is over 18 and they have serious and persistent mental illness, this is where people go for services. IHH, Integrated Health Homes. ACT, which is an evidence-based program called Assertive Community Treatment, which meets people in the community. And then the group homes, which you might hear of, but they're called MHPRRs, mental health, psychiatric rehabilitative residences. They're group homes. Usually they're about 16 in a group home, anywhere from 8 to 16. And we have 416 beds in the state. And generally they have to be at a community mental health for a period of time in order to get into a group home. And then general outpatient and specialty programs. Next. Those with serious and mental illnesses that cannot have problems just with showering, budgeting, taking their medication. These are individuals that could go into an IHH Act. Individuals within 6 months of turning 18, and they've already been living in a residential placement. They've been in foster care placement or in homes, and they've already been diagnosed with SPMI, serious persistent mental illness, and they have difficulties in daily living skills. They really couldn't function without living in a group home. The adults, they can be reviewed at 17 and a half and get their applications in. So they have a place to go when they get out of DCYF care. Next. So how do we determine who goes in a group home? To be honest with you, we want to make sure that we don't put someone in a group home, because the average group home for adult age is, probably between 30 and 40. So you have an 18-year-old, you don't necessarily want to have somebody at that age live with adults and see serious persistent mental illness. So, you know, there's a score, there's a test that they take, and it's called a daily living activity tool. And you score the individual's ability to function. Can they shower? Can they budget? Can they cook their own meals? If they can do all this, then it's outpatient services. If they need some help, an IHH or integrated health home team, they can live in their environment and just come in and get wraparound services. That's a lower score. And the highest score is an ACT, and that's where someone can't function at all and really needs this group home level of care. Next. The ACT is an evidence-based practice that helps people with serious persistent mental illness, that if they didn't have this group home, they could become homeless, they could end up in a psychiatric crisis, they could be hospitalized, they could be suicidal, they could end up in the ACI. And that's not where someone with a mental health issue really wants to be. You can't see where I am, but I can move my camera a little bit. Right there's the ACI. And that's where the grounds I'm on, and there's not a lot of mental health treatment in, right? So this allows people to get 24 hours a day, 7 days a week services. And this allows them to live in a community and to have case managers and care managers take them to the store and bring them where they need to be and make sure that they're taking their medication and get to their doctors. Next. So this ACT team surrounds people. It's not just case managers as yourself, but these also have master level clinicians, those specialists, psychiatric services. So if you ever went to go work at one of the CMHOs, you would be part of a team, and that team would meet on a daily basis and talk about what the needs are of that person. This is the adult services. Next. In order to be paid by Medicaid and to get these group home services as ACT program eligibility services, someone needs to have one of these diagnoses. These diagnoses are schizophrenia, as you can see, bipolar, major depression recurrent, all the way down to psychotic disorders. When adolescents, in my experience, they don't generally get these diagnoses until a little later on in life. They might get them. You'd see a lot of bipolar, you see a lot of major depression, some obsessive compulsive. What you're going to see, especially the younger they are, is a lot of conduct disorders, a lot of aggressive behaviors, a lot of just combative, but generally people are, you might see obsessive compulsive, but generally you don't see a lot of psychotic or delusional disorders until, and schizophrenic affect until someone gets older, but you might see some. I just want to make sure that you know what a DSM-5 is, and that's a diagnostic book where you can get more information on each of these diagnostics and what it would present at, someone would look like, what would they traits they would have. This is more counseling down the road, but if that's your lattice, if your hope is to become a counselor, or you're moving on to be a psychiatrist, or your goal is to work as a nurse, this is education that you will need. So sometimes it's good to kind of just do a little self-learning yourself, because then you're involved in the conversation. You are not eligible to diagnose anyone, but it'll help you know who you're working with. For example, a borderline personality disorder, generally you need to set very strong boundaries with, or that person, you don't give them your home phone number, because they will call you at home, and so you have to have really strong boundaries, personal boundaries for yourself. Supervision will also help you understand these diagnostics and also help you protect yourself as well as protect the client, and help him see that this is part of the illness that he has, that these symptoms that he is showing is part of his illness. He's very smart, or she's very smart, and intelligence has nothing to do with this, but these are some part of the illnesses, and that's why it's really important to take medications to kind of curb some of the symptoms that they might be showing with some of the behaviors. Next. So what's presented as an adult is really comprehensive case management, as you can see. This isn't just transportation, this is really management of and health promotion, and understanding that when someone leaves inpatient or goes to another level of care, that you're right there with them saying, how are you doing? Are you eating? Are you taking your medications? Are you, is there someone I can call that will help you? Who can be with you? Just really affirming the community and social support services. We have the Teen Recovery Center in Providence that can help someone just feel like they're not alone and have that, and that's so important. Next. And this is just really, we have most all of the group home residential beds are primary psychiatric services. There is one in Central Falls that has both mental health and substance abuse disorders, but we're looking to grow that. Any questions so far? All right, we're moving along. Next. How do you get into a group home? It's not just because your parents don't want you living there anymore. You get into a group home because you are cycling. You have a history of institutionalization. You have gone to the hospital for suicide attempts or danger to hurt somebody else, or you might be court ordered to go there because you're refusing to take your medication voluntarily. And they can, in this state, we can involuntarily order someone to take their medication, especially if they're being hospitalized, they have a history of violence. And usually there's co-occurring issues, both substance abuse, might be even developmental disabilities, but we want people to be in the most restrictive environment, and in this case, but this is not where we want an 18-year-old. An 18-year-old, we want a lot of case management. We want a lot of looking toward the future, of hope of what they can become and do. Next. In the event you have to refer somebody from DCYF that needs a higher level of care, I went through this last 4 slides because I wanted you to see how you do it or how it's done. An adolescent diagnosed with disabilities, mental health, starts with DCYF determining that they might need a higher level of care. They will then determine if it's just DD or it's behavioral health. On the left-hand side, you'll see we have homes for those with developmental disabilities. And generally they've been diagnosed very early on, but they have to be diagnosed with a developmental disability before they're 21 in order to get into some of our DD homes. They have to do SS, which is a SID, which they review everyone's records to make sure how they're doing in school, how they've done at work, what the disability is, and they need some psychiatric services. That's on the left. If someone in the middle has both DD and behavioral health, they have to decide which process would best suit the person individually. So they have to complete both applications. And on the right-hand side is if it's just behavioral health. Generally, it's bipolar or schizophrenia. And the determination of, do they really need residential? Because truly, we do not want to put someone in residential that doesn't need it. If they do, you can complete or assist them with getting a residential packet to complete as early as 17 years and 4 months. So when there's a smoother transition when they age out of the system. And if they don't need that level of care, we want to make sure that they connect to the adult services, because adolescent services end and the adult services, the sooner we can connect them and make a slow transition from adolescent services to adult services, the more successful. So your case manager would hang on for a long period of time with the person while they're transitioning into adult services and just kind of process what it's like to see a new counselor or being in a new facility. And we try to make sure that that goes very, very slow. Next. I've included this in the slides just in the event that you need to or find that someone needs information. They're turned 18, they call you, I'm out of the system, I don't know what to do, how do I get some help? Well, these are the phone numbers for their local. So if they live in Pawtucket, for example, or they would call Gateway that specific number at Gateway. So look at the area that you're providing services, whether or not it's Chepachet or South County. Know what your local community mental health facility is. Know that phone number, because there's some people that the only way you're going to be able to help them is to assist them with either going to BH Link right away if it's an emergency, or help support them while they wait for an appointment for community mental health centers. Next. Wow, we're moving along. Okay, so I wanted to talk about now, we talked about adults. I'm going to talk about transitional youth. And this is the guide that we talked about. I'm going to drop off 80 of these to Tanya. Excuse me, there's two parts. I have the hard copy that you can have. And then I also have the electronic copy that you can look at. And I wanted to just talk briefly about what's in the book. Next slide. These are the questions that get answered. So this book was made by a lot of focus groups, working with a lot of adolescents. This was a grant that came in through SAMHSA, asking the questions, if I am an adolescent transitioning to adulthood, what do I need to know? First of all, what is behavioral health? Because, you know, the terminology gets, and to validate, very important that 1/5 of young adults ages 18 and 24 have had a mental health issue in the past year. 1/5 is the same amount of number of this group that said that they haven't had they've never had information on this. So it just shows you that you're pretty educated, you're showing up, you're getting training, but most people don't even know what behavioral health is, and that it's common to have you know, a mental health issue, and that it's nothing to be ashamed of or be fearful of. There is help, and there is, but you have to go and get help. How do they personally take charge of their health? So when you turn 18, you run into some problems, because when you go into community mental health facility and you're 19 years old, they're going to ask you for your records. They're going to say, where did you go? I mean, what medical decisions have you had? If you don't have a parent around, and very often that's the case, people don't know how to get that information. So there's a listing of where they can get their health records, how they can get their medical records, and also know what their rights are as an individual. They have a right to refuse treatment. They have a right to go to treatment and not include anybody else in that treatment. There's 42 CFR Part 2 for substance abuse, where they have to sign a release to allow anybody to get information about them. So there's lots of rights that they have. What happens when you turn 18? What does that mean? Does the, you know, skies open up and rainbow of money come flying out? No. What does that responsibility mean? How do they get health insurance? What is a community mental health facility? The health insurance options, who to call, what information will I need? Maybe I'd like to go to school, but I'm not smart enough. Well, let's see what you can do to go to college. Let's see what you can do. I don't have any money. Well, maybe we can see if you meet, you know, the eligibility rate for some funding services. And what to do in a crisis. What is a crisis in substance abuse disorders? So this book is a really good guide that you can give to them, as well as have that information for yourself. Next. So this is just an outline of what healthy transitions is. So healthy transition it's to help you, it's to help case managers, nurses, psychiatrists, substance abuse specialists, anyone who's working in a team to help participants meet with the personal goals. We have a youth coordinator here that I'm going to introduce you to in a little bit to talk about how he can help or get information to you and provide a training to anyone who's interested. But we also have healthy transition programs, which I'm going to have Jordan talk about in a little bit, and what they can do if you find somebody that's transitioning that would need more services after leaving Tides, that maybe we can help you with. Next. All right, I am going to stop here for a second. Tanya, can you click on bhdhri.gov?
I can, and I suspect I'm gonna have to reshare my screen. Is this a video or is it just a link?
Just a link.
All right, so let's see. I may have to stop and then reshare my screen. Let's just double check.
Okay.
Can everybody see the State of Rhode Island BHDDH website?
I can't.
Yeah.
No.
Nope. Okay, so I'm gonna stop sharing and then I'm going to reshare.
Okay.
There we go. All right. How about that, guys? Is that better?
Good.
All right, awesome.
All right, so this is, I want to be able to make sure that we can give you other resources, and that's exactly why I'm here. So this is our website, bhcdh.ri.gov. And if you click on any of these, let's go to, anyway, peer recovery family support. So with that one.
Do you see the new screen?
I can.
Peer recovery and family services?
Mhm.
Okay, perfect.
So if you look on the bottom, so these peer recovery services are really important. They're support services, and I can tell you more about them, but we have them both for substance abuse and mental health. These are phone numbers to be able to kind of connect as well. And could you scroll back up for a minute? Because I just, before you, yep. I also want to stop right there, right there. This right here, see the, my arrow, like you can actually see where my arrow is. Sorry about that. So under family support services, you'll see it says mental health advocate. A mental health advocate is someone that the state pays for that can speak for someone who has a mental health illness that may not be able to speak for themselves in a court setting. So there are a lot of, so if an individual feels like they're being mistreated by the court or they're being mistreated because of their illness, this is a person that's paid for by the state to advocate specifically for them. So I wanted you to know where to find that number. I also wanted you to see where NAMI is, and NAMI is you can hit that too if you want to. Sure. NAMI is an organization that specifically we pay for to make sure that family members. So if you have a child with mental illness and you don't know what to do because the person's out of control, he or she might be, I don't know who to turn to. Nobody talks to me. You know, if I have a child and that child has cancer, I've got neighbors that are coming over my house giving me casseroles or something like that, right? But if you have a child with mental health issues, people don't know what to say to you. They don't know how to talk to you. They give, so they just don't. They pull away and they go like, oh, that poor family, right? This is other family members talking to other family members about arrest, what to do about just information for them to support mental illness and the recovery aspect of it. This is a very recovery-friendly environment for family members. My experience, 13 years working with kids, is you cannot work with just the kid. You can't work with a kid and then have him return home and have that household responding in the same way as it responded before, because it's not too far down the road before everyone returns back to the same kind of behaviors that they were doing before. In a family with mental illness or with a family with substance abuse, every family member needs treatment. And some may need more. I have treated kids where I've had them in my office and I've met their parents and said, well, I understand why you use drugs now. I might. Just being honest with them, if there was a lot of violence in the home and there was a lot of illness in the home, it doesn't justify your use. I understand it. But going forward, what can we do? And so sometimes it means getting help for the family behind me, in which a kid very often is coming in going, oh my God, I'm acting out, but you should see how bad they are. I'm not that bad. They're the crazy ones, right? So this is a way for family members who might say, I don't know what to do. I've tried everything and nothing is working. It's all my fault. If my mother had bipolar, so it's my fault. It's like, stop with this. My fault, your fault. Let's just like everybody get healthier and look at what you can do. So NAMI is a support group for family members. And we can go back.
Yep, just give me 1 second.
Sure, you're doing good.
There we go. Can folks still see this now? We're back at the BHDDH website? Okay, perfect.
And I want you to see, if you see individual and family information, it says Linda Mahoney right there. This is a way you can contact me. Up above the squares, the last sentence in the block right there. There's my email address. There is my phone number if you need me. That I just wanted to make sure you knew where to access that in case you lose any information going forward. There's also lots of information about employment and housing information. This is on our BHDDH website. Okay, so we are going to take a 10-minute, let's bring it back at 1:15. And I'm going to introduce you to Jordan, and then we're going to go look at the substance abuse side. And if anybody can put some questions into the question box before we start, that would be helpful. If you have a computer and you can go on, if you go back to the Zoom screen for a second there, Ms. Tanya.
By Zoom screen.
My Excel screen.
Oh, your Excel. Okay, yeah. 1 second.
We're going to start by looking at a website.
Let me just share it because I'm seeing it. I'm not sharing it with all of you.
All right, so why don't we just, if it's all right with you, Tanya, we'll break and then we'll come back at 10:15 and I'll go get Jordan.
Okay, and is this the website that you want right here?
We're going to go to that one
next.
Yep, we're going to go to that one next.
Okay, perfect. I'll get it queued up.
Thank you. All
Thank
right.
you. Have a good day, guys.
Hey, Tanya, if you want to have me go through the screen, if that's easier for you, I whatever.
It's up to you. Some people aren't comfortable having to talk and and do this. So if you're comfortable doing it, I'm here. I keep checking the chat. I keep expanding the screen to see if anyone's raising a hand or anything, but that's fine.
Yeah, sure. I don't mind. I have a big mouth. I can talk and walk and I do a whole bunch of things. As I get older, I might need you more. All right, so I thought that I would break up the education part and wanted to make sure I introduced you to someone that works here at the department that works at the Healthy Transition. And him and I were talking about how old he was when he started working and what he did. And I thought you might want to ask him a couple of questions. He was a case manager. He was about 25 when he started. And he has a couple of just words of thought to share. I think that is important. It's one thing to learn about the resources. It's another thing to learn from individuals that are older and have been through where you might be now and how they might be able to share their wisdom and experience. So I'd like to introduce to you to Jordan Maddox, and please ask any questions that you have, but he's just going to talk to you about his experience being around your age doing case management. Jordan?
Hey, Jordan, welcome to the training.
Good morning, everybody. How's everyone doing? Good? Thumbs up. We're doing good?
Not too bad.
Awesome. So, like she said, I'm Jordan Maddox. I'm the youth coordinator here for the Healthy Transitions program. And a lot of what I do is helping get the youth's voice heard and have it represented more because we know this is an adult-dominated health system, it's mainly geared towards adults, but we also know that the youth need to be heard as well, because a lot of, and when I say youth and young adults, I mean 16 to 25. So a lot of people, once you turn 18, you're considered an adult, but we all know when you're 18, your mind isn't quite adult ready, right? So a lot of what I do is I go out in the community and I reach out to different resources that can help benefit the youth, and I funnel it through our Healthy Transitions program. But I'm not here to talk about that. What I'm here to talk to you guys about mainly is in the field where you guys are at right now. This is probably the most important level, because you guys work with the youth directly and the young adults directly. You guys have conversations that they might not want to have with certain people. So the biggest advice I would give is, while you're doing your work, it's okay to feel how you feel, but it's very important to listen to what the youth are telling you, because they'll give you the answers that you're looking for without it being how you want it. That's the biggest thing I could give you guys, is don't be afraid to open your mind, understand where people are coming from. Like I was explaining to Linda, I had people on my caseload that were 18 to 70. So I received so many different perspectives, but at the same time, it was hard for me to focus on what each one needed, because the caseload was so big, it was the range was so wide. But I think for you guys have a certain age group that you guys are working with. And that's ultimately the best thing for you guys, is just concentrate on this age group. What are they looking for? What are their needs? What are their concerns? What do they respond to? What don't they respond to? And that's really what the most important thing is. Questions?
If you want, you can put them in the chat and I'm happy to share them, or you should feel free to unmute yourselves and to ask Jordan directly.
And you could ask me anything. I don't hold back. I'll be honest.
I'll kick off the questions. Jordan, as someone who, started her career as a case manager, I remember just the struggle and the juggle of, like you said, even when we have the same age group, the diversity of that caseload and the magnitude of it, right? So do you have any suggestions for how to manage just the bigness of all of that stuff?
It's like anything in life, you have to prioritize, right? So let's say you have 3 patients and they all in dire need. Let's say one is hungry, one wants a job, and one is homeless, right? The one who's hungry, we can solve that problem fast, right? The one who's homeless, it's going to take a little bit more work, but you can, that one's probably one you want to focus the most on. The one who needs a job, you work on the little things to help him get a job. So it's prioritizing. You don't want to put the person who's hungry first all the time. Not to say their needs aren't important, but hunger is temporary. Homeless is something that people live with, no pun intended. So you want to just prioritize it in that aspect, as far as, okay, well, this person needs a home. So I'll focus my morning on reaching out, going to different, if you got to put them in a shelter first to secure housing, because what a lot of people don't realize is some shelters, once you're locked in and you have a bed in a shelter, they'll help you get an apartment or find housing, but you have to get in the shelter. So it's that going to the shelter in the morning or in the evening, it's calling different places, even volunteering at certain places can help people find housing. So it's just navigating the system. You guys are going to have to learn how to do things a little unconventionally, as far as looking for housing, jobs, and trying to put food in people's mouths. Like I remember I used to have to take a guy every Tuesday to the food bank at a church. So I would prioritize it. Okay, you get your food on Tuesday. I'll work with you on Tuesday and Wednesday to make sure you have everything you need. Thursday, Friday, and Monday, call me if you need me, right? Because I was all he needed. Compared to my guy who was homeless, it was every day. He was in the office from 9 to 10 every day. We're calling places. We're trying to find him a job to secure some employment, to put some money in his pocket. It's just really prioritizing the needs of your patients and the people you work with, because not everyone, like right now I'm starving, right? So if I come in the office and I say, I'm so hungry, it's not the end of the world. Like, I'm gonna eat eventually, right? But you just have to really just say, okay, you're hungry now. Maybe a sandwich, an apple will get you through now until lunchtime, and then we can set you up here where they're giving out free lunches. But you also have to network, because if you don't know who to go to, it's gonna make it 10 times harder. So a lot of things that I did was, I just would call people, and I still do it to this day. Hey, I work for such and such. I was just wondering if you guys gave out meals, or do you guys do food drives, or whatever it is. And if they'd say no, they say no. It's not that big of a deal. But if you don't at least make the effort and at least show the clients you're working with that you care about their needs, it's pointless here. So just really prioritize the needs of the clients. That's probably the most important. Like, I had a caseload of 25, and at any point I'd get a phone call. Oh my God, I'm hungry. I'm like, all right, take a deep breath. I'll get there in an hour. I'll take you to the market, whatever it is, but I'm not going to drop what I'm doing because you're hungry. You know what I mean?
Right.
Now, if it's a consistent every day around lunchtime, you don't have a meal. Okay, let's try and set you up where we can get you somewhere where they're giving out lunches until you can sustain food. Or do you have EBT? How are you managing your EBT? Like, that's the role of a case manager. Is all of that. Like, okay, you have EBT. How much do you spend on actual food and not 7-Eleven?
Right.
You know what I mean? It's just really, being a case manager is the hardest position, I think, in the mental health field. And I say that because you do everything. You do therapy, you do case management, you do counseling, you do budgeting, you do everything. So it's really just prioritizing what's important for the patient as well as for your caseload, because you don't want to get burnt out after a week of being pulled in 7 different directions.
Right.
You have to take some type of control of your schedule, and your clients will appreciate that if you say, look, I'm busy right now, but I'll get to you by 10 o'clock.
We have 2 questions. I'll give them to you, one, and let you answer, and then I'll go to the next one. So Laura's asking, can clients outreach healthy transitions on their own, or do case managers have to call first?
Okay, so you can walk in if you want, or a case manager can call and refer you to the Healthy Transitions program, or you can just walk in and say, I would like to be a part of Healthy Transition at the Providence, and you do an intake, and you start the process that way. But you can walk in or you can be referred. Yes. Okay,
nice. So both. Kelly's asking if you have any advice for providing working with clients who need help but have difficulty engaging or admitting that they need help.
So with the youth, especially your population, if you're looking for them to admit they need help, get your binoculars, because you're going to be looking for a while, right? Because put yourself in a 19-year-old's position. Nobody at 19 wants to say they have anxiety, or they're depressed, or they're stressed, because of the stigma that comes with it, right? So for myself, I'll give you a personal experience. I have anxiety. I deal with anxiety to this day, but I've learned how to control it. But when I was 19, it was everything but anxiety. It was my upbringing. It was this, it was that. It was all the excuses instead of me just realizing that it's me. So it's going to be hard to have a young adult admit that they're dealing with something or they need help, right? But the minute they say they need the help, that's when we have to spring into action. I've had a guy, I swear to you, he was 24 years old, and he came in my office every day, did cocaine, he did drugs, and he didn't think he had a drug problem until he lost his apartment. When he came in, he was like, I'm ready to stop. So everything we worked on for a year led him to say he was ready to stop, and I had to be ready once he told me he was ready to stop and get him lined up with the resources that he needed. So it's gonna be hard, it's not gonna be easy, but you have to stay consistent and firm. And that's how that works. You just have to be consistent with them.
One of the things that I heard you say, that the relationship that you build is important, really listening to them. And then
absolutely.
And then you use the word knowing how to navigate a network, that you need to be able to, you said, spring into action and call those resources to bear for each person. And when they're ready, you have to be there, it sounds like.
Yes.
We have, I think, two more questions. The third one is, how did you manage or navigate finding resources when you were a case manager?
Google. I'll be honest.
Amen.
Seriously, if I food banks and what, so the key to resourcing or to networking and expanding your resources is, if so now you've met me, right? So I'm part of your network, but it doesn't stop with me. You ask me, who do I know? And then once I connect you to somebody else, okay, who do they know? And that's how you continue to grow your network. So I wouldn't be sitting right here if I just didn't call anyone and just like, I don't know anybody, so I can't help you. It's, you have to pick up the phone, make the call. Sometimes it's uncomfortable. Even if what I used to do, because I used to get nervous, is I would sit with my manager and we would role play. He would be the service that I was looking for, and I would be me, and we would go through it. And he would say, you're nervous, you're saying too much, or whatever it is. And you get it out of your system. Now it should be easy because you guys, it's phone calls. Hey, do you guys do food services or whatever? No, we don't do that because of COVID, but you can call this place and they'll direct you. And that's how you network. Network is the most important thing you do as a case manager, because you have to know the information. And if you don't know your supervisor, and down the line, and if you know something your supervisor doesn't, you should always share it with your supervisor, because someone else on the team might have the same question.
Excellent. Speaking of networks, and the fact that you've started in many ways a new network connection for them, Jessica would like to know if you can share your contact information with the group.
I just met you guys.
No.
I'll put it in I'll put my email in the chat as well as my office number. Yeah, and reach out to me. I'm always available to help. That's my email and my office number. Any questions you have for me, like I said, I did case management for 3 years, so I'm pretty familiar with the ins and outs of it. And like I said, I did it for 18 to guys that were over 70. So.
Any other questions for Jordan?
Thanks, guys.
Yeah, thank you, Jordan.
Mask back on. All right.
Thank you, sir. Hold on. Well, that should wake you up, right?
Yeah, thanks for that, Linda. That was great.
Well, yeah, and you should know that Jordan was working with serious and persistent mentally ill people as well. So he's had at a very young age, and I was telling him I was doing this presentation, and I said, what would you say, excuse me, if you were looking at yourself, you know, being 25 years old, sitting on the other side, excuse me, maybe new to a profession? And his words were profound. He was like, I didn't know enough. Just keep learning. Just keep asking. You know, don't be afraid to ask. And I was like, come here. It's going to sound a lot better coming from you than from me. So thank you for your time. And Jordan does mean that he is there. And I've got a feeling you'll hear a lot about that young man. He's going to go far, for sure. All right, so another resource. This is Google. You can Google this if you want. If we can pull up the website. All right. So we're going on to the substance abuse side, and I wanted to make sure that Rhode Island is a very small state. We have a great college. It's the Brown University. They have specialists, epidemiologists, which pulls together data. So we took everything from the Department of Health, everything from Department of BH, DDH, the governor's office, and we put it on this one website. So all you have to do to learn anything about the opioid crisis truly is to go right here. As a state opioid treatment authority in hearing, I mean, last year, we're up about 38% overdoses from last year. A lot of that has to do with COVID-19. It also has to do with the junk that's on the street. The fentanyl that's out there is in cocaine. It is in prescription pills. We have dealers that have pill press that are making pills that look identical to a prescription pill. I mean, back about 2 years ago, You could tell if fentanyl was in a prescription pill because the Percocet didn't look like a Percocet, didn't have a really strong M on it that you normally would find. What happened is now you can put a counterfeit pill right alongside a prescription pill and you can't tell the difference. So we needed to make sure we got information out there. Rhode Island was one of the only, one of 14 states that reduced the opioid overdoses from 2018 to 2019. But like all the other states, we're back up there again. We expect, I think the projection is about 408 people this year alone will die from an opioid overdose. And that's not counting the hundreds and hundreds of people who do overdose that did not have a fatal overdose and may have multiple overdoses before they do have a fatal overdose. But this is where you need to go. So I'm going to go to a couple of things. So if you want information about, if you go to About, if you want to know what we do, you hit anything about the opioid crisis, what we're the action plan, the task force. We call it PORI. It's called Prevent Overdose RI website, but this website has the most data that you'll be able to find. I'm going to go back and go to learn more. If you hit fentanyl, you scroll down, you can learn about what fentanyl is, how it affects people. You can keep going down. You keep going down about naloxone. If you, hopefully everyone in here has heard about naloxone and understands how to get it. And if you go out of this screen, yeah, go all the way up. Above, see the very above top says request naloxone. Yep, right there. If you hit that, you can actually have naloxone mailed to your home free of charge. If you just hit the where it says request naloxone, you have it in English and in Spanish. It doesn't come with a sign that says naloxone coming to your house. It's discreet. You just have to give them some information about who you are, because this is a grant in order to get money to distribute naloxone. And I bought 10,379 kits of naloxone in the month of December, so we could distribute this and flood our streets with this. So this is just the basic information that you need. It will be mailed to your house, no charge, free. You can go to CVS, use your health insurance. Most is covered by Medicaid with no co-payments. You can go to a local recovery website, you know, all of this, and that's all free. All right, go back to the main page. I'm keeping you busy. You can go.
Enjoying it, Linda.
Excuse me?
I'm enjoying it. This is great.
There's a lot of information here. Under just, you don't have to go there, but under learn more, there's a section for how to help. Yeah, you can hit it. Sure, help a loved one. So a lot of times, especially the girls more so than the guys, you know, well, you know, or my dad and my mom or something along that line. We talked, if you look on the right-hand side of this, it says Connect with REST, which is a local support group. This is a support group for family members. So if you have a family member that their child's using opioids, whether or not they've already had an overdose or they're just worried about them, they don't know how to talk to them, they're trying to yell, beat them out of using drugs, that doesn't work. This is an evidence-based practice where the other family members teach family members how to keep yourself safe, you know, hide your checkbook if you need to, but at the same time, set some really strong boundaries. If you have a friend who has substance abuse, you know, what you can do to protect yourself as well as protect them. So this is a plethora of information. I mean, I just can't begin to tell you how easy it is. If you could spend 10 minutes and just go through some of these and look at them, you will have more information than you had yesterday, for sure. And then most people have, because they don't take the time to do that. It doesn't take that long. Let's go back to the main page. I wanted to go to back where you said learn more. That same line, go all down to medication assisted treatment, okay? Hit that one, please. And if you scroll down, There's a BH link number that I gave you earlier. Medication assisted treatment is buprenorphine and methadone, and keep going. And there's some facts, but more importantly, there's a map if you keep going. Oh, case is not on there. Sorry about that. Might be on another page. I thought I know this by heart. Oh, apparently I don't.
Could it
So
be in this, Linda? Could it be in one of these links?
You can try to hit the, yeah, try to find opiate treatment program. There you go. All right, there you go. Now you go. So this, I just want you to see this map. If you wanted to find just a detox, if you scroll up just a little bit, no, scroll up to the top. Yeah. No, that's not it. Okay. Anyways, there's a map where all the methadone clinics, all the detoxes. If you hit the button where it says detoxification, yeah, there you go. Okay, you scroll down, it's going to show you all the detox centers. If you try going up, yep, and then you want to find Massachusetts, Connecticut, all that information's here.
Okay. Wow.
If you wanted to hit just residential treatment programs, right down there, yep. And it will hit you all the residential programs. You go down, if you hit a button, yeah, scroll over it, it will give you the address, the phone number, and who they treat. So there's only one adolescent program that you just were over a minute ago.
Caritas?
Caritas, right. And that is generally for those who, it's right over here.
I just had it.
You did, it's down a little bit, it's in Cranston. Oh,
Live in Cranston, I should see it. I think I made the map a little bit bigger. So
it should be right there. There you go.
There we go. Caritas House.
There's the phone number. There's the website. You can find out more information about what you need for admission to a residential facility. And they're co-ed. And so the website will give you contact information. So there's a couple of things I wanted to go back. So scroll back up to the main page. And let's go to prevention. Prevent an overdose. Yep. Look at fentanyl strips, if you would. I don't know how many people are familiar with fentanyl strips, but you will be by the time I'm done with you. All right, can we go to that clip? Will you be able to play that clip? Try playing it.
Let me just share my sound.
Okay.
And folks can let me know if you see the video. If not, I'll just go back out and come in.
Hi everybody, I'm Ashley Perry from Project Weber Renew. I am the intervention case manager and I'm here today to teach you guys about fentanyl test strips. This is what the fentanyl test strip looks like. You would put whatever substance you would have. If you were using cocaine, you would just put a tiny bit of the substance into this vial. You would put half of this water. You would place the test strip in the water and you would twirl it around and sing happy birthday. When you're done with that, you would take it out, place it somewhere, and almost instantly it would be able to tell you if there was fentanyl present or not. So if there's 2 red lines, it means it is most likely negative for fentanyl, but we still say proceed with caution because you don't know what else is in that drug. If you need fentanyl test strips or know anybody that does need fentanyl test strips, you can come and visit us at 640 Broad Street at our new drop-in center located directly across the street from St. Joseph's Hospital.
Thank you. And the reason why I wanted you to see the fentanyl strips is because you can go to this website and you can share this with someone. They know where they can go and they get it free. So you need to see that there are some fentanyl analogs out there that are really elephant tranquilizers. Okay, so someone uses a drug one day and they can get it from the exact same person the next day. and the next day they have a different analog of fentanyl in it, and that analog only would need the tip of a pencil amount in xylazine, some of the drugs that are out there that could kill them instantly. So a lot of the work we're doing right now isn't so much opioid overdose work as much as harm prevention and reduction to keep people from dying, and because that's where we're at. So we ask people, don't use alone. Test their drugs with fentanyl strips. Now they might be resistant to you and say, well, you know, I don't want to use up something that I need. You tell them to use an empty bag, put the water in the bag. There's always residue in the bag that they can use and they can test. So if they do find it's fentanyl and they choose to continue to use, that's up to them. But have naloxone handy. Don't use alone. Have somebody next to you, or, you know, call somebody and say, if I don't call you back in 2 minutes, you know, come barging in the door with naloxone. But it's about keeping people alive right now. And things are moving to the place where, it's, you know, we don't want people using drugs, but if they are using drugs, we need to reduce the harm of their dying. And the fentanyl, the potent amount of fentanyl is, like I said, found in cocaine. 1 out of 2 overdoses in 2020 were because of cocaine that had fentanyl in it. And then we also have found it in Xanax, Adderall. These are drugs where people, especially adolescents, take all the time. And they think, oh, no, he has a prescription. Well, we don't know that for sure. Or I got some Adderall, but they don't know where they got it from. And they might have gotten it from Dev, and Dev may have gotten it from Trey, and Trey may have gotten it from Odessa, and Odessa may, they don't know the original source. And so testing it is just a safer way if they're going to go that road, but your job is to educate them about the toxicity. At the end of that, she made a point of saying there are no clean street drugs out there. And I got to tell you, from somebody who goes to the ME's office, you know, quarterly, I'm really tired of seeing young adults. And that population right now is growing. My guess is if I asked anybody in the chat room, if you know somebody you've lost from an overdose, out of the 15, I would think we would probably get at least 5, but you know, somebody, or, you know, because it's just, it's out there. But, so I wanted you to have resources. I wanted you also to see the data. And I also see that button where it says get help. Top right hand side near the get help up there. It's a blue button. Yep, right there. It's in Spanish and Portuguese. You can hit get help and it will show you all the different resources that you need. Again, so if you need a quick place to go to, there's your resources, phone numbers, Massachusetts, Connecticut, excuse me. And if you don't have naloxone with you and you would like a training on how to get free naloxone, we're going to show you how to get that too. Any questions on the website? All right, we're going to skip back to the the PowerPoint. All right, so as Jordan says, is think out. The best thing you can do to help me do my job is to break the discrimination and the fear that people have about getting treatment. And please express that it is a legitimate brain disease. When you first start using substances, it might be not affecting your brain, but it's like doing it on a regular basis then becomes a habit then becomes a disorder then becomes disease of the organ. And an addicted brain is this what it looks like in a scan. This is prolonged use, is caused pervasive changes, and that's why some people need medication. So if you have your own biases about methadone or buprenorphine, please know that this disease is bigger. I'd much rather, I know plenty of people who are back to work, who have a healthy life, who are on either buprenorphine or methadone, and they don't die, and that's a really important piece. And then a lot of times people say, well, you know, they tried methadone or they tried buprenorphine, but they kept relapsing. Well, I put this graph on the right-hand side to show you that people with a substance abuse disorder relapse less than people who have high blood pressure and they're supposed to change their diet and not eat ice cream and exercise more and do all the things they need to do to stay without medication. There are people who use one time and all of a sudden they run with an addiction. There are people who use many times and it doesn't become an addiction for them. We don't know the brain enough to know why, but we do know that there is some predisposition, whether or not genetically through family or whether or not it's the environment. You know, if you've been around an environment where there's lots of substances, it's really easy access. But people do relapse, but that does not mean that they cannot find recovery and stay recovery. So these are the two stigma questions. If you can help with and digest them and determine what your own personal thought is about medications, assisted treatment, or about this being a disease, this is a really first step. Thank you. Next. All right. So if you're going to understand substance abuse, if you're brand new, this is talking to the brand new person who's never, ever, ever done this work before. There are different stages of recovery, different stages of treatment. The first stage, we do promotion. You'll see a lot of commercials on TV. Talk to your children, don't use substances. Prevention has 3 stages: universal, selective, and indicated. Basically, this means is sometimes you're targeting your prevention to people who've never used. Some people with high risk to use, like children of alcoholics or children of substance use. You want to teach that. That's a lot about teaching. And then there's treatment, when there are interventions, peer recovery work, getting people into treatment. And then there's maintenance in recovery, where people have to have recovery capital. We're going to talk about that a little bit. So these are the 4 pillars: prevention, rescue, treatment, and recovery. Next. So I don't know your experience or knowledge base about what different levels of care, but the American Society of Addiction Medicine determines that people should be at the least restrictive level of care. Not everybody needs to go into a hospital. Not everybody needs to go into a residential program. Not everybody needs detoxification. People who generally need detoxification are with alcohol or benzodiazepines, which are life-threatening if you stop using on your own. You would like to feel like it's life-threatening coming off for an opioid, and sometimes you need the detoxification, but generally people get really sick. It's not going to stop their heart, but they might need the comfort meds they need to kind of be able to make it to the other side. Outpatient treatment basically is individual and group sessions. Intensive outpatient is more frequent. It's like 3 times a day, 3 hours a day. Partial hospitalization is 5 days a week, usually about 5 hours a day. We have lots of residential substance abuse residential treatments, both gender specific. They average anywhere from 2 weeks to 90 days, depending on the insurance and what the situation is. But they stay there and they're not usually able to kind of go home at all. Medication assisted treatment, as we talked about, you might hear it as Suboxone, but that's the brand name. It's really buprenorphine. Naloxone is, which I'm hoping you all get by the end of this session for free. You already started the mail order, as we started earlier. And then peer-to-peer recovery centers. We have the Teen Center on Main Street in Providence, but we have 5 recovery centers throughout the state. They're geographically placed. And there below is the, I believe below is the connection, but if you go on to Prevent Overdose RI, you'll also see the recovery centers. The Anchor Recovery Center in Providence, oh, there it is, okay. One in West Warwick. There is East Bay's got the Hope Recovery Center. Tommy Joyce does a great job there. Community counseling, CCA has a Serenity Center in Woonsocket. And we have PSN, Parent Support Network, in Newport and Westerly. So these are centers where you can just go to, talk to a peer, and they can connect you to any other services that you need. They might help you with food. They might help you with shelter. They might help you get to a meeting. They might just talk to you. They just validate being in recovery is okay, and that we can be there to support whatever you need to do. Next. We have recovery housing. This is the website. The NAR on the top right-hand corner is the National Alliance for Member Recovery Residents. We have standards. So the state is paying for recovery housing if people meet the eligibility criteria. And the eligibility criteria is basically they can't afford to pay for recovery housing by themselves. Okay. If you call BH Link, you can get more information on how to get to a recovery center. They will connect you on the waiting list and what it's like. So we're closing down here toward the end, and I wanted you to also, this again is self-serving for me. We did a public survey why people aren't getting into treatment or what people think about those with substance abuse disorders. And we've been trying to break the image that, you know, you have to be something you don't, because it can happen to anybody. All right, so let's do a little exercise because you all started to fall asleep. I can see you in the little window. Can't fall asleep, sorry, can't do it, can't happen. All right, we're doing exercise, ready? You don't have to close your eyes, but if you would close your eyes, it kind of helps the scenario a little bit. Imagine that you're walking down a street that you walked down 100 times in your life. And as you're walking down the street, coming toward you is somebody with a substance abuse disorder. In about 5 seconds, they're gonna walk by your left-hand shoulder. I want you to take a mind picture of what that person looks like, what they're wearing, how they're walking. And when they cross your shoulder in 3 seconds, I want you to take a good sniff and see what they smell like. Ready? 3, 2, 1. All right. Let's see who the bravest person is in the room. Someone want to tell me what they saw? You have to unmute yourself to do that. Was it male or female? Yes, Odessa?
I'll just get right to it. Like, I saw somebody that looked like me. Just your average person. Not male or female. I just saw a body, but the person was like clean cut, just had on like regular normal clothes. And I couldn't smell, and you said take a smell, like I couldn't smell anything.
Okay, that's good. Trey, you want to try?
Oh, I had a male. I had him wearing a scarf, sweater. I would say posture wasn't, maybe a little bit of a slouch. And I would say the smell was probably like a musty smell, probably like, you know, you have like a sweater that's been in the back of the closet for a while. I think that's the image I got.
Okay. Anyone else?
Dev is saying that he smelled a musty smell as well.
Deb, was your male or female?
For me, it was a male.
How old?
Mid to late 30s.
Okay. Anyone else?
I pictured mine a bit younger than that, probably like late teens to early 20s.
Okay, and the smell?
Kelly smelled alcohol, and I believe Junior is saying he also smelled the musty smell as well.
So, Kelly, was yours a female or a male?
It was a male, African American, probably middle, like early 40s. You know, baggy clothes. Like the walk was like hunched over, and I smelled alcohol.
Junior, yours male or female?
It was a male, probably like, I don't know, I guess I picture like in his 30s or something like that.
Okay. Anyone else?
I had a female in her 50s. Not gonna lie, it's personal experience. I pictured my bio mom. So I smelled cigarettes and alcohol.
Yeah. First things is going to come to true is someone that you have seen, right? Because I said it's a familiar street that you've been on for a long time. I do this all the time with people. I love to hear the answers that I get. You know, generally it's a white male, older. I get trench coats a lot. I don't know why I get trench coats. I have no idea about that one. The smell consistently is urine, right? And cigarettes. But it's not who I've treated over the years. Over the years, I have treated neurosurgeons. I have treated police officers, especially police officers who drink, cough medicine in the car so they don't get caught. You know, they take the huge amount of alcohol that's in cough medicine. They don't realize there's also 1,000 milligrams of Tylenol in cough medicine. It's like, why are you doing that? That's like destroying your liver. My point is people get stuck with this mind picture of what someone is. And when you're treating an 18-year-old or 16-year-old and they think of somebody that old, that's not me. That can't happen to me. I'm not that bad yet. I'm not like them. I'm not like my mom. I'm not like my dad. I'm not like my uncle, And so you got to flip it back and go, well, let's talk about you and how has your substance or your alcohol affected your life? What have you lost? Have you lost opportunities? Have you lost friendships? Have you lost time? Have you blacked out? These are all things. When I ask people, what do you think about people who have substance use? Or I get it all the time. I get like, oh, you work with them people. I don't know what them people is because that makes me crazy. I get a sense right away that I understand that they already have their prejudice built up. And, you gotta sit on your hands sometimes when you're talking with people and not kind of say what you'd like to say when you can feel their prejudice or their discrimination or their fear. We did a survey, and when we did the survey, we interviewed over 1,000 Rhode Islanders, and we asked them questions about their attitudes towards someone with a substance use or mental health issues. Can we put the survey back up, Miss Tanya?
Sure.
Thank you.
No problem.
I would like to spread this information far and wide. So some of the key findings that came out of the survey that we did is that everybody knows somebody who's struggling with behavioral health issues, right? They know, it used to be 1 out of 4 people knew somebody close to them that had a substance abuse problem. I believe now it's more like 2 out of 4, if not 3 out of 4, because it's so public and people are coming forward where before people kept it quiet, right? Here's a good one that we found out interviewing. We're talking about 1,000 different people. It wasn't just 1,000 people in Providence. It was a scope on Qualtrics. It was a survey. It was done across the state. They had so many males, so many white males, so many Asian males. We went down the road to make sure we took the same population in Rhode Island and we asked the questions to the same demographics. And they want to help people who have a substance abuse problem. They really do. The best one that came around was 91% of Rhode Islanders believe that a person should not feel ashamed to get help. Do you imagine if you took that sentence and you shared that with 4 people and said, this crazy blonde lady was giving us this presentation today, and 91% of Rhode Islanders believe that people shouldn't be ashamed to go get help. That could make a difference in someone asking for help. Because with adolescents developmentally specifically, the way you talk to them is that everybody feels this way, then generally they try to feel the same way because it's part of the developmental stages. So these are some of the survey findings I think you could share. Next slide, please. I love this. We all know somebody, 74% know someone who struggled with mental health issues, if not yourself. So that's more common than people think. 66% know or have known someone who has struggled with substance use. So that's more like 3 out of 4. No, yes, I don't know. 2 out of 3. Thank you. 92% have told, I didn't pass math, I had to work on that. So 92% have talked with that person about their behavioral health issues. When we ask people, why didn't you talk to somebody that you knew had a substance abuse problem or a mental health problem? They said, I didn't know what to say, you know, and I didn't want them to ask me something I couldn't help them with. And sometimes it's like, do you need help? And listen. Next. Stereotypes that still continue to endure, and we know in this world, especially, there's tons, but in the form of substance abuse and mental health, 53% agree that relapse is part of the recovery process. But that also means like there's 47% of people believe that people should never relapse once they get into recovery. Like they should have a magic wand, and that magic wand should come around and should tap them on the head and ta-da, they're cured. And to be honest with you, that's the problems I have with doctors who don't want to deal with someone with mental or substance abuse problem, because this is a chronic disease. Chronic meaning it lasts for a lifetime in some cases. Physicians get trained to get a diagnosis, to get the medication, to treat them, and either you cure them or they go into a place where you can't cure them. They want to cure people, and this necessarily isn't a cure. This is more understanding this is a chronic disease. People do get healthy. People do have wonderful lives in recovery, but there are some people who just continually relapse, and they need different things at different times. The other one that still endures, 60% believe medication is appropriate for someone with substance abuse. There's a lot of people, especially AA, NA, 12-step programs, abstinent programs, you know, you don't need medication. You just spiritual surrender, you know. There are some people who need medications. Next. At the beginning, I asked you what recovery friendly was. This is how people not only get into recovery, but stay in recovery. Anybody can stop using substances, but in order to stay in recovery, these are the care management, the case management things that they need to do to work on. There are 8 dimensions of wellness. It's from SAMHSA. And I wanted to make sure we talked about SAMHSA because recovery capital is kind of like money. If you have no money, and you have no roof over your head, and you have no food, it's very hard to stop using drugs, because you can A, sell drugs and get money. And if you're selling them, you're going to get high because you can't be around it that quick. And not, excuse me. You need a roof over your head, you need food, but you also need to kind of develop into the person that you really want to be. And that might be finding a career that really makes you feel happy and enriched. It might be taking care of yourself physically, getting good food and health. The best way you can really help someone is role model that behavior, eat healthy, you know, sleep, get your hours of sleep, do the things you need to do that you're telling other people to do. Social and sense of connection. People, especially adolescents, especially young adults, they need to stay socially connected. With COVID, we still have Zoom meetings. Zuma, that's a dance. Anyways, we have various things that people need to do. Spirituality is not necessarily going to church. It's having a sense of grace. It's understanding that there's a meaning in life, a power greater than you. Emotionally, get your mental health issues unstable. A lot of people with substance abuse do not also have co-occurring disorders that don't show up sometimes until they stop using their substances, because they've been masking their depression and their anxiety for a really long time. Environment, non-toxic people, staying away from environments, go to environments that are supportive. Financial, get some training. Look at, so many people don't know how to save money. They get loans for like 99% interest to something that's going to affect them the rest of their life. Get some education about how to look at your financial future, and intellectually find creative ways to expand your knowledge and skills. This is how people get recovery capital. We now have recovery-friendly employment. These are jobs that will support people in recovery. They have peer recovery coaches that work with them at their job. So there's so much that's happening. I want you to see that there's a lot of work in recovery. It doesn't come easy. It's hard if you're doing it, it's almost impossible if you're doing it alone. Care managers are really important. Case managers, I can't tell you the importance. I've had, as a CEO, I've had multiple staff underneath me. I always learned more about a person, sometimes by just the person who was transporting somebody from one place to another. Sitting in the car, you're not threatening. You don't have access to DCYF. You don't have access to their funding or the court system, but you're somebody that they can trust because you're kind and because you're doing this because you really care. I'm going to close one last slide. How can I help and not hurt? We all make mistakes. We all have struggles and even regret things in our past. But you are not your mistakes. You are not your struggles. And you are here now with the power to shape your day and your future. So this is just something I wanted to leave behind for you. If you can't help, don't hurt. Choose your words wisely. Take care of you first. The better you are, the better you can help. Next slide. Last but not least, these are your words that you want to choose wisely. Get words out of your mouth. Hopefully they're not there. Dirty drug screens, stay clean. These all say that you're dirty, that there's something wrong with you. Don't, your own personal opinions, as Jordan said earlier, use the words that are helpful and are clinically beneficial. Say things like persons with a substance abuse disorder. We are now saying persons with substance abuse condition because the word disorder is messing people up. Person living in recovery, not an ex-junkie. Persons living with an addiction, person arrested for a drug violation. So persons who are non-compliant or bombed out, really? Person's illness is flaring right now. They're not doing well. Medication is a tool. Had a setback. These are things, by choosing your words wisely, you're role modeling about the benefits about being in recovery and not judgment or inflicting shame. Next. So again, this is the information one more time. And if you need me, reach out and contact me or Jordan. And I just wanted to see if there's any questions that I can answer. I am here to answer them. Is anything helpful? So I know for the next class for tomorrow.
Feel free to put it in the chat, or you can certainly, unmic and share your thoughts out loud.
I can take it. Bring it on.
I know
I would just like to say that I think that going over the fentanyl resources was very helpful. And I definitely personally will be signing up for the training. So I'm very glad that you showed us that.
Good. That's helpful. Thank you. I appreciate that.
We have a couple of folks. This was really helpful. The websites you provided were very helpful. Thank you. This was insightful. Thank you for your time. I am putting in the chat a link to the evaluation for this module. You can access it just by clicking on it, and it will automatically just come into our database here. And then the way we've set this training up, you'll just have once a week. We really wanted to be mindful, as much as Tides wants you to be immersed in the training, they also don't want there to be any adverse impacts to the folks that you're serving. So I hope that the way that we've scheduled training so that it's just once a week and for a half day doesn't add any additional stress or impact your ability to be able to do the important work that you're doing. We will have a couple of trainings that will be entirely asynchronous, and I'll make sure to let you guys know that in advance so that I can give you the link to them. And as long as you have it done before you get to the next training, I'm happy. If you're like me, sometimes I do my best work at 3 o'clock in the morning. So on those situations, anytime that you want to access it, you'll be able to, and I'll make sure that I include links for the evaluation just so that there'll be a little bit of flexibility. I appreciate your time today. I certainly, as an administrator, I often don't get the chance to sit in on training. So it was a secret treat for me. I'm not going to tell anyone that I got to actually sit and take all this in, because some of the resources, especially the web ones, Linda, were ones that I haven't had to navigate and we're definitely not familiar with. So I learned a lot today, and I feel excited to get to see some of the folks who are joining this field of practice. And I'm looking forward to the rest of the training with you and to kind of being a part of your network. Thanks so much, guys. And thank you, Linda.
And good luck to all of you. I really mean that. This is a great profession. You don't make a lot of money, but there's a lot of treasure here. And when you look back on your life, you look back that you gave. You really did something to make a difference in someone's life. You can't put a dollar amount on that, but this part of your life is for learning. As you get older, you'll get to the next part is for earning. And at the end part of my life, which I believe is now, is for serving. So I hope I served you well. Thank you.
Thank you, Linda.
Thank you.
Thank you. All right. God bless. Good luck.
I'll stay on if anyone has any questions. Otherwise, you can feel free to hop off and enjoy the rest of your day.
Thank you.
Is the Thursday portion of the training a different aspect or like a different trainer? Is that what you meant by that?
That's a great question. So I sent out a schedule. I emailed the cohort separately, and in it I included the name of the training, the trainer, and the date. So the next training that you guys have coming up, if I'm not mistaken, I want to say, I'm just looking for my cohort 1 training schedule. So the next one that we have is Thursday. It's suicide prevention with Dr. Prachi Keen.
Yeah, that's what I have.
Yep, perfect. So it's twice a week for half a day, so the equivalent of a full day. So there are a couple of there are a couple of trainings that have multiple parts, like the DCYF and NAMBY is a two-parter. The trauma is a two-parter. That's the one that will definitely be delivered asynchronously. And I'm waiting for confirmation on 2 more. There might be a couple. If it's 2 parts, you're only going to go once. You'll have the class, and you'll have a break, and then you'll have the next class. Sometimes if it falls on a Thursday, Friday, then the part 2 will be the next week. But you should be able to tell from the schedule if it's a part 1, part 2 continuing. And I'm going to send out the copies. I just got Dr. Keen's stuff on yesterday. So I'll make sure that I send out a hard copy of that. I mean, a soft copy by email, but that will be in the manual that we're printing up for you guys.
All right. Awesome. Thank
Excellent.
you.
See you later.
Bye.
Bye-bye.